The following podcast is part of a certified educational activity titled Restoring Control in von Willebrand Disease, Collaborative Approaches for Delivering the Right Treatment for the Right Patient at the Right Time. Access the entire activity and complete the post-test at peerview.com/CCN860. Downloadable slides and practice aids are also available.
Welcome to our session on restoring control in von Willebrand disease, collaborative approaches for delivering the right treatment for the right patient at the right time. My name is Nathan Cannell, and I'm a hematologist at the Brigham and Women's Hospital and Harvard Medical School in Boston. And I'm joined today by my colleague, Nick Cacciola-Price, who is a hemophilia nurse practitioner from Weill Cornell's Hemophilia Treatment Center. Today, we're going to discuss some of the ongoing challenges in caring for people living with von Willebrand disease, review current diagnostic and treatment strategies, and explore ways to improve patient care. Let's go ahead and get started. Von Willebrand disease is incredibly complex and is divided into several types. Types 1 and 3 are what we call the quantitative types, which means that there may not be enough of the von Willebrand protein circulating around. Type 1 is the most common form and accounts for about 75 to 85% of all people living with von Willebrand disease. This is a partial quantitative deficiency, and it represents a significant number of the people who are symptomatic with von Willebrand disease. Type 3 von Willebrand disease is incredibly rare. It is the rarest of the forms. It is autosomal recessive, meaning that you have to inherit it from both parents. We think that it's about 1 in 1 million people, and essentially there is no von Willebrand factor in circulation. Think of type 1 as you make it, you just don't make enough. With type 3, you don't make it at all. When we look at the different laboratory patterns, we see that type 1 von Willebrand disease has low von Willebrand factor antigen, platelet binding activity, often measured by ristocetin cofactor, and low factor VIII activity. If you test the multimers, which isn't typically necessary in type 1, they are normal and present in all forms, just decreased in total amount. Type 3, you will see that there is a virtual absence of antigen activity and factor VIII activity as well. And if you measure the multimers, they will also be absent. There is also a subtype of type 1 called type 1C, in which the levels are very low, but if you measure the von Willebrand propeptide, which is a marker of synthesis of von Willebrand factor, you'll see that that's actually normal. So you're making it. It's just getting cleared away too quickly. Type 2 von Willebrand disease falls into a category we call a qualitative form, which means you make it, it just doesn't do one of its jobs properly. This is also autosomal dominant, and there are several different defects depending on what the actual functional defect is. Type 2A is probably the most common form of type 2, in which you have absent high or intermediate weight multimers, and there's abnormal platelet binding. The high molecular weight multimers are the most hemostatically active, so the loss of these leads to the bleeding symptoms. Type 2B von Willebrand disease is a gain-of-function mutation in which there is spontaneous binding of von Willebrand factor to circulating platelets, which are then cleared from circulation. These patients oftentimes have a thrombocytopenia on their CBC. We see abnormal multimers, and so this you'll hear about later. Desmopressin is relatively contraindicated because it releases more of the abnormal von Willebrand factor, causing worsening thrombocytopenia. Type 2N von Willebrand disease really just doesn't have its proper binding to factor VIII, so the antigen and activity may be normal or only slightly low, but you see a very low factor VIII level, and this can sometimes be confused for hemophilia A. And then finally, there's type 2M von Willebrand disease, where there's decreased platelet binding, but these people have normal multimers. So my typical approach to trying to remember these is A has abnormal multimers, M has multimers, B binds to platelets, and N has no 8. There are a lot of different factors that complicate getting to a diagnosis of von Willebrand disease. For instance, as someone ages, their von Willebrand factor levels go up. This happens in everyone, whether or not they have the diagnosis. So somebody that might have lower levels in early age may have normal levels if tested in middle age or as they are elderly. There are other conditions that will increase circulating levels, such as pregnancy, use of estrogen. Sometimes we see this in inflammation and physiologic stress. And then there are other factors that will lower levels of von Willebrand factor. People who have type O blood typically run lower levels than people who have type A, B, or type AB. Von Willebrand disease is very challenging to diagnose given the heterogeneity and the fact that levels can change over time. And there's not a single laboratory test that is going to be able to give you your answer. This is why it's important to do multiple tests and to do it in an algorithmic approach. One of the big challenges that people with von Willebrand disease experience, particularly people with type 2A, severe type 1, and type 3 von Willebrand disease, is GI bleeding. There are oftentimes anatomic defects that come about, angiodysplastic lesions throughout the gastrointestinal tract that form as a result of low von Willebrand factor levels, which lead to increased circulating vascular endothelial growth factor. When we look at angiodysplasia, it can be difficult to find the lesions. You see somebody, you know that they're GI bleeding because they have dark stools, maybe iron deficiency anemia. You do an upper endoscopy, colonoscopy, you don't find it, and it's only on specialized techniques such as video capsule endoscopy or angiography that you can find this. And there's a need to treat the bleed, but also to try to prevent the underlying development of these angioectatic lesions. I want to thank our partners, the National Bleeding Disorder Foundation, for working with us today to support this CME talk. The National Bleeding Disorder Foundation has a whole wealth of resources available online. You can go to their main website, or you can go directly to some of their patient-facing resources at betteryouKnow.org. This is an initiative aimed at supporting healthcare professionals to recognize the signs of a bleeding disorder and what next steps to take, as well as supporting individuals who are experiencing bleeding but are undiagnosed and helping them figure out how they should try to approach their diagnostic journey. Our goals for today are to increase your awareness of the clinical burden of von Willebrand disease and how it impacts quality of life, strengthen your understanding of the evidence and differences between modern von Willebrand therapeutics, improve your ability to develop personalized care plans based on disease characteristics, bleeding history, and patients' goals, as well as enhancing your skills in facilitating shared decision-making and coordinating team-based care of your patients with VWD. At this point, I'm going to turn it over to Nick to take us through treatment for von Willebrand disease.
Thanks, Dr. Cannell. My name's Nick. I'm Nick Cacciola-Price. I am a family nurse practitioner at the Weill Cornell Bleeding Disorder Treatment Center in New York City. And today we're going to jump further into the understanding of modern treatment options with von Willebrand's disease. So this slide gives us a brief timeline of medical advances in the discovery and treatment progress with von Willebrand's disease. And you can see how cryoprecipitate was the initial treatment option until the first generation of plasma-derived products began coming onto the market. With further advancements, the von Willebrand gene was discovered, followed by the first recombinant von Willebrand product to hit the market in 2015. So here we see an overview of the various von Willebrand concentrates currently available with their purification methods, viral inactivations, and FDA approval status. What's important to note here is the variability in the ratio of von Willebrand factor, rhistocete, and cofactor units of each product in relation to the amount of factor VIII, or in the case of von Willebrand, the recombinant von Willebrand product, a lack thereof. So why is this important to consider when you're choosing a product for your patients? Well, as Dr. Cannell mentioned earlier with discussing the diagnostic methods of subtyping, some products may produce better level outcomes depending on the patient's baseline levels. For instance, HUMAP holds a 2-to-1 ratio on von Willebrand factor to factor 8, whereas Will8 has a 1-to-1 ratio, and von Bendy contains no 8. So a type 2 patient may have extremely normal factor 8 levels, and choosing a product such as von Bendy may not give quite so high an elevation on the 8s to the level of risking thrombosis. It's also important to note that as von Willebrand factor stabilizes factor 8 in circulation, it protects it from the degradation, and you can see more factor 8 accumulation in maybe a product like Will8 than you would over HUMAP. In addition, von Bendy, which carries no factor 8, would need to be supplemented with a factor 8 product if they're very low on their baseline levels. I believe von Bendy recommends a supplementation with 8 if your levels are lower than 40%. So you can see how a more in-depth diagnostic subtyping can lead to optimal treatment decision-making and better outcomes in bleeding management. Looking at the long-term efficacy of plasma-derived HUMAP, it's no surprise that overall 93% of patients experienced good or excellent outcomes across the board with on-demand treatment, prophylaxis, and surgical management of factor treatment. Similarly, a phase 3 study looked at the efficacy and safety profile of recombinant von Willebrand prophylaxis in severe von Willebrand's type 3. Now, to review, von Bendy contains all multimers, but is not exposed to the proteolysis by Adams 13 during the manufacturing process, allowing all the multimers to stay intact. So patients with bleeding events requiring recombinant von Willebrand therapy over the past year were studied with a switch group of patients that were on HUMAP for prophylaxis and switched to von Willebrands. And the findings suggested that recombinant von Willebrand prophy works much better than on-demand treatment and maintains a similar level of hemostatic control in patients who switch from prophy with a plasma-derived concentrate versus a recombinant concentrate with a good safety profile. And this study shows patients receiving prophylactic recombinant von Willebrand treatment focus on both annual bleeding rates and annual joint bleeding rates remain low, unsurprisingly, suggesting effective bleeding event prevention. So while von Willebrand factor concentrates can be an excellent treatment option for both the prevention of bleeding, bleed management, and perioperative management, they have their limitations. An important one being the inability to self-infuse or barriers to learning self-infusion. Not only that, but some situations involving outpatient minor procedures may not have the support to administer some medications, and that's where some of these other therapies may be an excellent and appropriate option. Desmopressin, or DDAVP, is a synthetic version of vasopressin that acts on V2 receptors to increase water absorption in the kidneys and stimulating the release of already present factor 8 and von Willebrand factor from the body's endothelium levels to adequate hemostasis. This also causes an antidiuretic response, so it's extremely important to note and educate patients and post-surgical units on fluid restrictions, as fluid overload can lead to severe hyponatremia, resulting in seizures, coma, and death. I don't say this to scare, but to be aware, as it really can be an excellent option for our patients under the right circumstances. With this medication, we expect to see a 2 to 3-fold increase in baseline levels. This works very well in most type 1 patients, but not so much in type 2s and not in type 3s. However, it's important to consider what we call a DDAVP challenge to a newly diagnosed patient to assess adequate response. And this is done by getting baseline CBC, CMP, just to get a baseline sodium level, and your von Willebrand panel. And after the medication infusion, we usually repeat von Willebrand levels at the 1, 2, and 4 hour mark from the start of infusion. And this is done because of what Dr. Cannell said earlier about some patients can't mount they can mount a great initial response, but then they clear it, as in von Willebrand type 3. And this is not something you want to learn during a procedure. Because it's only administered, because it takes what's already in your endothelial tissue, it really can only be administered maybe 2 times, once in every 24-hour period, with maybe a third administration. But once your stores are depleted, your body needs more time to rebuild. This medication may also cause some side effects such as facial flushing, headaches, tachycardia, and as mentioned above, hyponatremia. Though with the right patient and provider education, this can be a great option for minor procedures and injuries. It also comes in an intranasal form. Please note that the dosing is usually 0.3 micrograms per kilogram, and we usually don't exceed 20 micrograms in a dose. Now, antifibrinolytics are clot stabilizers given either orally or intravenously that prevent the breakdown of clot formation. It's an excellent option for mucocutaneous bleeding in areas of high fibrinolysis. This medication can be an excellent standalone option for minor dental procedures with a reduction of heavy menses or epistaxis. It can usually do very well with minor invasive procedures. It can be used with DDAVP for tonsillectomies or GU procedures, and it's generally well tolerated with only minor side effects as headache or GI upset. And thirdly, we have hormonal therapy, and these are also extremely useful in increasing von Willebrand levels and reducing the severity of menorrhagia in some of our women and children with bleeding disorders and heavy menorrhagia. So looking at some of what's going down the pipeline, there's a lot of promising things to look forward to. Von Vendi's now in phase 3 trials for the pediatric population. Emicizumab, which is a bispecific monoclonal antibody that replaces factor VIII by binding to activated 9 and 10, is being investigated in its role in thrombin generation. So we're not really sure what role it really plays in the von Willebrand treatment, but we're looking for hemostasis options there. There's also anti-protein S antibodies, which bind to protein S with the idea of creating a deficiency in protein S, which will increase clot formation, and also the anti-von Willebrand adapters that's shielding, that's protecting the platelets in circulation, which could be helpful for the type 2 von Willebrand's patients. And so overall, the core von Willebrand initiative, we're trying to provide a unified framework for assessing treatment options. It's designed to promote the uniform collection and use of outcomes in clinical trials, and it aims to provide comparative effectiveness analysis and determine the value of different treatment options.
So we're going to move on to a case and discuss whether this individual, Amy, has von Willebrand disease. She's a 16-year-old female presenting with severe bleeding after a dental procedure. She's also noted to have heavy menstrual bleeding, which improved on a combined estrogen-containing oral contraceptive. She was diagnosed with iron deficiency anemia, and she has easy bruising. Interestingly, when you take a family history, you find out her mom has heavy menstrual bleeding and actually had postpartum hemorrhage requiring transfusion. So the things that we're going to discuss today is what symptoms should raise suspicion of a bleeding disorder. I would say the fact that she has heavy menstrual bleeding and has heavy menstrual bleeding enough to cause iron deficiency anemia is enough to say that you should probably proceed with consideration of von Willebrand testing. But you also have this additional information such as easy bruising and a family history as well. In terms of testing that should be done, the typical testing as first-line therapy includes a CBC, particularly to look at platelets, a PT and a PTT and fibrinogen to look at whether your hemostatic system is generally intact, but importantly, a von Willebrand panel, which typically includes an assessment of the von Willebrand antigen, how much you make, the von Willebrand factor activity, how well it binds to platelets, and a factor VIII level, how well the von Willebrand factor is protecting factor VIII. Now, what is the role of the multidisciplinary care team in diagnosing and coordinating care? I'll say that as a hematologist, I'm very much involved in the diagnosis and workup of individuals, but I work as part of a whole team. And so one of the questions that I may pose to Nick is, what is it that you do in the clinic as part of the whole team that includes not just physicians, nursing, social work, physical therapy? How do you view the multidisciplinary team in the diagnostic journey?
Well, we work very closely especially with menorrhagia and our up and coming, adolescents. What are we looking at in terms of bleeding? Usually there's 3 types of bleeding options when it comes to menorrhagia. There's an inherited or congenital bleeding disorder. And so we're kind of one check mark on that journey. The other is OBGYN. We're looking at, is there a structural issue going on? So we work really closely with the GYNs to diagnose. And the other thing is endocrine. So we want to look at these children's hormonal levels and decide, are we dealing with a bleeding disorder or are we dealing with something endocrinology based? So we really work closely. And so it's really important that we get a bleeding assessment tool score. We look with, the family history to make an informed decision of, do we move forward with bleeding disorder workup, which never really hurts, but then are they coming to us from GYN as a referral where they've been checked out there? Are they coming to us from endocrinology? So we work really well with that trifecta of interdisciplinary team members to to diagnose this patient and to move forward with the best way of treatment options.
Great. And if Amy is diagnosed with von Willebrand disease, what are our next steps? Well, some of it may require doing further subtyping, figuring out other comorbidities that may contribute to it, and making sure that we have a plan in place. So there are guidelines for the diagnosis and management of von Willebrand disease. These were internationally collaborated guidelines between the American Society of Hematology, the International Society of Thrombosis and Hemostasis, the National Hemophilia Foundation, now the National Bleeding Disorders Foundation, and the World Federation of Hemophilia. And as you can see here, you can use the QR code to go directly to the available guidelines. Bleeding assessment tools are a key component to figuring out if somebody has a bleeding disorder, and also can be very helpful in documenting severe bleeding phenotype. For people who have a low probability of VWD, in other words, they have a negative BAT score in the primary care setting, this may be enough to say you don't need to do further testing for VWD, but you may need to work up individual symptoms. Once you get into the hematology clinic, the pretest probability is high enough that a BAT score shouldn't be used to determine testing, but it may be helpful in documenting phenotype. So if Nick has a patient in his clinic who's moving from New York to Boston and is going to be seeing me, if he tells me that patient has an ISTH BAT score of 18, that conveys a very high bleeding phenotype as compared to somebody with maybe an ISTH BAT score of 6 or 7. Now, you can see from the figure here, there are a lot of different tests that can be done in second and third line testing for further subtyping, and not all of these may be available in your center or may require a send out. It does take an entire team to diagnose von Willebrand disease. When you're looking at all the individuals who have touch points with people with bleeding, a lot of times it's actually general internists, hospitalists, and emergency physicians, as well as obstetricians and gynecologists. Hematologists are often a referral point, but we're not the first ones usually to see the symptoms and to hear about the symptoms. And I would also like to point out that ear, nose, and throat docs oftentimes have to deal with workup of bleeding related to nosebleeds and people bleeding after tonsillectomy. So what are the recommendations for diagnosing VWD? Consider use of bleeding assessment tools, particularly to document bleeding phenotype. There are specialized tests that can be used for diagnosis. You may need to repeat tests, particularly after a couple of months, because levels can fluctuate for a variety of reasons. And know that there's normalization with age. And genetic testing can be helpful in specific subtypes, but it doesn't have a role in testing and confirming von Willebrand disease in most forms in the same way that we use it in hemophilia. In terms of management, the next time we see Amy, she's 25 years old and wants to stop the oral contraceptive and become pregnant. How do we address questions around labor and delivery? Well, women with von Willebrand disease can have epidurals, so they can have neuraxial anesthesia. You may need to provide supplementation of von Willebrand factor concentrate. There are also risks of postpartum hemorrhage. I have a very low threshold to give tranexamic acid in the peripartum setting. Typically, I give a gram intravenously at the time of delivery and then continue this for 10 to 14 days afterwards. It can be done orally after the initial dose. The reason for this is because von Willebrand factor levels drop after delivery, return to baseline. However, there is a high risk of bleeding as the uterine lining is healing, particularly between days 7 and 14. There are guidelines from the National Bleeding Disorder Foundation's Medical and Scientific Advisory Council for pregnancy and perinatal management of women with inherited bleeding disorders, as well as carriers. I'll turn it over to Nick for case 2.
Thank you. So I thought this was an interesting case because it speaks to Dr. Cannell's talk about the GI bleeding with some of our von Willebrand patient members. And so we have a 77-year-old female who was diagnosed with type 2A von Willebrand's disease, and it was complicated by chronic GI bleeding. She was diagnosed in the setting of abnormal uterine bleeding, and actually went without a hemophilia treatment center for most of her adult life. She developed a severe GI bleeding later in life, was found to have AVMs, and I believe she had about 5 hospitalizations before she presented to a hemophilia treatment center. She was treated multiple times with HUMAP, octreotide, blood transfusions before she was finally, referred to our treatment center. Her baseline level factor VIII levels were normal, and so what was a real concern with each multiple hospitalization to control the bleeding was her factor VIII accumulation went into very dangerous levels throughout the course of her hospitalizations. And so von Willebrand's disease is an acute phase reactant in general, and in the scenario of a GI bleed, it's complicated with factor VIII administrations, and you're worried about thrombosis as well. Eventually, we had planned procedures of endoscopy and elective surgeries. So the discussion here is, what are the treatment options that should be considered for the management of acute bleeding episodes in long-term care in the setting of factor products that may not be the best option? And what is the age-related considerations of note when managing this patient? And how should the care team plan to monitor this patient post-procedure and post-op? So she ended up coming to our treatment center, and we switched her to a recombinant factor product, Von Vendi. What this did was it calmed down her VIII levels because there was not that accumulation. And she responded very well to this medication. We had to do some troubleshooting, so we brought her in every 3-day intervals to assess her von Willebrand panel to make sure that her ristocetin cofactor activity and her antigen were in adequate levels, but to also make sure that her factor VIII wasn't going too high. Eventually, she was spaced out to every 4 days and then every 5 days, where she started to have some bleeding symptoms. And so she was pulled back to 4-day infusions. She learned self-infusion, and now she's doing extremely well. There's been no GI bleeding or hospitalizations, and no anemia in the past year. So as Dr. Cannell says before, it really takes a team to manage these von Willebrand related bleeds. We work very closely, depending on the setting of the bleed, in terms of GI and what's the best option moving forward. And we're also dealing with surgical management. What is the estimated bleeding loss? How invasive are these procedures? What's the recovery time? And how do we best monitor these patients? So this generally shows guidelines for von Willebrand management, which I think is a fantastic slide. It kind of breaks down each subtype and what the best treatment options may be. So type 1, desmopressin usually works really well in a majority of cases. However, I would say that for major surgeries, this may not be the best product because, as stated before, your body really needs time to rebuild those stores. So von Willebrand factor concentrate is usually the front line in our major surgeries. The different types also respond differently. So type 2 desmopressin is rarely effective. You might see, some benefit, I believe, in type 2N, but overall, it's not something that we use as frontline. Factor concentrate would be the way to go. And type 3 would be the definite option because you're replacing what they're missing. So here we see ASH, ISTH guidelines, NHF guidelines for unique bleeding situations in von Willebrand disease. And as you can see, for minor surgeries, you want to target a von Willebrand activity of greater than 50, and throwing an antifibrinolytic on board helps with clot stabilization and healing. Major surgeries, you definitely want to target 50 for at least 3 days, and extend as needed. And you can do that by monitoring levels in the postoperative period. For heavy menstrual bleeding, also, hormonal therapy works, antifibrinolytics. In some, unique cases of severe bleeding, it may be best and most beneficial to teach the patient how to infuse and give factor concentrate for the duration of the period. And neuraxial anesthesia, you always want to target 50 to 150. As Dr. Cannell said, we can clear these patients for an epidural with the right care. Dr. Cannell, Maybe you can discuss with us a little bit about how you approach prophylaxis in your patients.
So one of the things that I think about when I approach prophylaxis is that the guideline recommendation is that in people who have severe and frequent bleeds should be considered for prophylaxis, but we don't define what severe and frequent are. Severe and frequent are different for each individual person depending on the type of bleeding that they're experiencing and the impact on their quality of life. There really needs to be shared decision making because this is a big undertaking to do prophylaxis. And you have to understand the logistics. Is the person going to infuse themselves? Are there going to be family members who can infuse them? Particularly in younger individuals, will this require placement of a port or some sort of line so that they can access it? Do you have access to an infusion clinic or home infusion nursing? In terms of thinking of the product, there are certain things that you've already heard about that will determine whether plasma versus recombinant based products are best. And there's a dosing schedule. There are package inserts which will describe starting with twice weekly or 3 times weekly, but this may need some adjustment depending on how someone responds. When you make the decision that you're going to proceed with prophylaxis, consider when you're going to reassess that decision and do the touch points. Are you going to have somebody from the clinic touching base with them periodically over the next couple of weeks to see how they're doing? Are you going to make a decision that at 2 or 3 months, you're going to decide, is this something we're going to continue? In terms of patient preferences and values, that may feed into the plasma-derived versus recombinant. There are many perceptions of infection risk. However, we do know that plasma-derived products that are available today for von Willebrand disease are very safe and effective. And as you've heard, factor VIII accumulation is something that we have to think about because that increases risk of thrombosis. As I mentioned, what qualifies as severe and frequent, this is different for everyone. And the definition that you see here was taken from the randomized controlled trial that was available to us when we created the von Willebrand management guidelines. However, several other trials have come out since and have given varying definitions. And so it needs to be individualized for the person in front of you.
Take-home points. So you always want to consider patient and product-specific considerations, factor VIII levels, bleeding risk, thrombosis. You want to consider initiating antifibrinolytic therapy in preparation for these planned procedures. Always encourage obtaining PK measurements to determine procedural plan. If you have the ability to monitor in real time post-op, that is optimal. And bleeding symptoms and the need for prophylaxis should always be periodically assessed.
So I'm happy to share that the National Bleeding Disorders Foundation has multiple resources that can be used. There's the Journey to Know program, which will guide individuals through the diagnostic process. There are risk assessment tools that can help both clinicians and patients have a discussion about what are their risks related to bleeding disorders. The Medical and Scientific Advisory Council has numerous documents that are evidence-based, reviewed by experts from multidisciplinary panels to contribute to improved diagnosis and management of bleeding disorders. Steps for Living is an online education platform with patient-friendly materials for individuals with bleeding disorders and also their families. The Own Your Path app-based program is designed to help patients navigate their life with a bleeding disorder. And there's also Victory for Women, a platform that empowers women with bleeding disorders through education, advocacy, and community support. And with that, we would like to thank you so much for joining us today. And I would like to thank my co-presenter, Nick Cacciola-Price. And thank you for joining us to learn more about how do we move forward for people living with von Willebrand disease.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, National Bleeding Disorders Foundation. This activity is supported by an educational grant from Takeda Pharmaceuticals USA Incorporated. To access all materials for this activity, visit peerview.com/CCN860.